Hello, everyone. My name is Lmillburg, and my research this semester focused on non-pharmacological prevention of delirium in the ICU. My PICO question is, in adult patients in the ICU, does implementing non-pharmacological delirium prevention-based protocols versus standard ICU care without formal delirium prevention protocols impact the occurrence of delirium over 6 months? According to the DSM-5, delirium is characterized by a couple different things. Attention disturbances with reduced environmental awareness. It can develop over hours or days, and it can fluctuate in how severe it is. It's often associated with disturbances in the sleep-wake cycle. And the prevalence of it is different based on the area of hospital or patient care that you're working in. It's most prevalent in hospitalized adults that are in like the general acuity area, and that is a 29 to 60% prevalence. In post-operative patients, it is 11 to 51%, and the highest is in the ICU population with up to 81% of patients who will experience delirium. It's frequent, and it is a serious complication among those, especially critically ill, which is my area of nursing. I've been in critical care at the bedside for 10 years. And then it can affect the patient's quality of life. It can affect the amount of time that they are in the hospital. It can even lead to long-term coma, death. So it's important to improve the quality of care focused on delirium prevention so that we can improve patient outcomes. There were 5 articles that were selected for my literature review. Of these articles, there were 3 randomized controlled trials, 1 quasi-experimental trial, and 1 interrupted time series trial. The first article that was analyzed is called "The Role of Multi-Component Non-Pharmacological Nursing Interventions on Delirium Prevention, a Randomized Control Study." This was produced by Kasaboglu and Inc. in 2022. There were 3 groups in this. There was 1 control group and then 2 intervention groups. With the first intervention group, they received daily recorded messages that were pre-recorded, and they listened to that would help to orient them. This was done by staff, and then after they received that twice a day. After the first orientation message, the daily newspaper was read to them by staff, and then they used eye masks at night for sleep. The second intervention group received the same interventions, however, it was family members that did the orientation message and read the newspaper to them. Statistically, there was no difference in the first group that received the interventions by staff to the control group. However, the second group that had the family participate in the recordings and reading of the newspaper did show a statistical significance. P was 0.027, and statistical significance was less than 0.05, indicating that having family present and active in the orientation of the patient helps to decrease the rate of ICU delirium. The second study is called "The Impact of Non-Pharmacological Interventions on Delirium in Neurological Intensive Care Unit Patients, a single study interrupted time series trial." And this was done by Rude et al. And produced in 2023. In this one, they had a multi-component non-pharmacological delirium prevention protocol or bundle that was implemented. It was labeled Underpin ICU. And this program, it focused on a couple different interventions to optimize. The categories were visual and hearing impairment, sleep deprivation, cognitive impairment, and immobility. There was no statistical significance from the control portion versus the intervention portion. The main thing that they were focusing on were delirium and coma-free days alive and the delirium incidents. So this was a level 2 on the Johns Hopkins hierarchy of evidence, and the quality was a B. The third one that was evaluated is called effectiveness of combined non-pharmacological interventions in the prevention of delirium in critically ill patients, a randomized control trial. This one was produced by Faustino et al. In 2022. And in this one, they were looking specifically at interventions to reduce the incidence of delirium, and these included things such as sleep hygiene, utilizing earplugs and masks, environmental orientation, where clocks and calendars were placed within the patient's view. There was therapeutic communication and early mobilization. And there was the incidence of the density of delirium was lower in the intervention group compared to the control group. However, the actual bundle itself did not show a decrease. There were 3 of the 5 that were of the interventions that were proven statistically significant in decreasing delirium. And those were environmental management, sleep promotion, and correction of sensory deficits with glasses. However, correction of sensory deficits with hearing aids did not show any significance in decreasing delirium. And periodic reorientation and cognitive stimulation also did not show any decrease in the incidence of delirium. So I guess it's 2.5, not 3 out of 5. This was a level 1 quality A research study based on the Johns Hopkins hierarchy. Article 4, which is called a new ICU delirium prevention bundle to reduce the incidence of delirium, a randomized parallel group trial. This was produced by Malik et al. In 2021. This focused specifically on patients that were mechanically intubated and ventilated in the ICU. It did not show a significant reduction in the intervention group as compared to the control group. The interventions were focused on sleep quality, analgesia and sedation, family contacts and bonding, early mobilization, weaning from the ventilator, removing lines, catheters, and drains early, and not receiving prophylactic antipsychotic medications and benzodiazepines. This was a level 1 on the Johns Hopkins hierarchy of evidence or of research and a quality of B. The 5th article, which is called a family intervention to prevent postoperative delirium in patients undergoing cardiac valve surgery, a randomized control study. This was produced by Lin et al. In 2024. And this one did show a significance in reducing the incidence of delirium in the intervention group as compared to the control group. The control group received standard care, while the intervention group received interventions of orientation, physiological care, cognitive stimulation, and sensory deprivation prevention, and this was done by the family members. So the family was educated on delirium prevention. They had structured family visits where they focused on reorienting the patient and providing emotional support. It was requested that they bring the patient's glasses, hearing aids, and any other personal belongings such as pictures to the patient. There was a significantly lower rate of delirium in the intervention group, but the interesting thing is that they also evaluated the family members, and they had a significantly lower rate of anxiety and depression scores post-intervention compared to the control group. So not only does it help to prevent delirium in the ICU population, but it helps the satisfaction of the family overall to be involved with the care. This was a level 1 and quality A on the Johns Hopkins hierarchy. The gaps that I found in the literature is that there is limited generalizability. Most of the studies that were conducted are single center and they're in specific geographical locations, such as the last one that had a statistical significance of decreasing delirium with the family involved. That was based in China, and they have different cultural beliefs and place more importance on family together, so that could have an effect on these outcome or these interventions being applicable to all patients. The populations were often small, although the power analysis that were completed did show that it was a significant number. They were small, so it does limit the applicability across all ICU settings. There was a short-term focus on the interventions and the results. It primarily reported on the delirium incidents during the ICU stay, and it doesn't focus on long-term outcomes for the patients afterwards, such as their cognition, their quality of life, any readmissions. There was not a cost-effective analysis. Most of the studies just stated that they were easy to implement. So the interventions could require additional resources, but it's not measured. And along with that, like focusing specifically on how easy it is for nursing staff to implement these strategies when they might be short-staffed or their assignments might be heavy acuity. That's really not discussed at all. Implementation inconsistencies. There were very few studies that assessed how well the protocols were implemented. Did the staff adhere to it? Were the results accurate? Because there was lack of blinding, that nature. And then the diversity of the patient population. So like one study focused on those that were mechanically ventilated alone. And then some of them excluded the patients that were mechanically ventilated or had pre-existing cognitive impairment, the high-risk populations, which in an ICU, you can't pick and choose your patients. So having patients that were not excluded in the high-risk category and a more diverse population will again help with the generalizability and accuracy of these studies. Implications for practice. Based on the results, some of the things that could be applied are involving family in the interventions to prevent delirium, allowing for frequent family visitation, possibly playing recorded family messages, and encouraging the family to bring personal items for the patient. Sleep promotion, specifically the ones that were utilized a lot in the research, were earplugs and eye masks for sleep promotion, clustering care and avoiding unnecessary interruptions, and then appropriate light utilization, keeping it dark at night and bright during the day. Early mobilization was a frequent intervention that showed a significant reduction in delirium. So begin mobilizing the patients as soon as safely possible to do so. One study also had physical therapy and occupational therapy that was involved in the intervention specifically. So they were trained and helped with ambulating that higher risk patient. When you're not able to get them up and move them, doing passive range of motion exercises. Environmental modifications. So this one is maintaining a clock and a calendar that is within view of the patient. Again, using the day and night lighting, as well as cues, getting them up and moving, doing fast during the day, that type of thing, to maintain the circadian rhythm and decrease their risk of ICU delirium. And then we mentioned the cognitive reorientation with pre-recorded messages of family, and that kind of goes along with involving family in the interventions. The future research that needs to be conducted based off of this is conducting multi-center randomized control trials. So it'll increase the statistical significance and the generalizability if we do multi-center, not just focused on one. So large-scale trials among diverse ICU populations. And then including the long-term follow-up. So what was the patient's cognitive function after they left, if they did have ICU delirium, if they did not, and do any certain interventions play a part in that? Are they functional? Do they end up being readmitted post-discharge? So a research study to evaluate the long-term benefits of these interventions or bundles. And then we need to do some studies that include evaluating the adherence to the interventions or the bundle. So we need to know if it's applicable, if it's applicable when applied in practice. Can we continue to adhere to the bundles? Are the staff being trained properly? Are they using the delirium scales to evaluate for delirium the correct way? And if not, what is the barrier to that? We would need to include high risk and diverse patient populations. So each ICU that is specified to a different population, such as cardiac patients, neurological patients, they're all going to have different complex needs and different pre-existing health conditions that are going to affect these patients. So we need to do some research that has all of them included, which speaks back to doing a multi-center randomized control trial, really getting all of those patients in there to make sure it is the most effective bundle that we can implement. And then the cost analysis. So the economic evaluations, it's really important because we are always doing things in the hospitals to reduce costs. If the intervention is something that can't be done unless you're one-on-one with a patient, or your patient acuity is too high and you're not able to get it completed, that's something that needs to be evaluated and factored into the bundle that we do. So we want it, of course, to reduce the ICU stay duration, any complications, and any extra resources that we would utilize. So it's important to have research that includes that cost analysis. These are my references, and thank you for listening to my presentation.